So this one is a really contentious and interesting issue. In real life practice, time to treatment failure is actually a very important endpoint, and it's actually guided, or we are guided by guidelines to suggest that this is a reasonable option to take. It implies that we are continuing on with our agent despite the fact that the patient has technically developed progression of their disease based on some sort of usually a radiologic criteria. However, we are fully aware that patients continue to derive benefit from the use of these targeted agents even in this situation. We are encouraged to consider localized therapies such as stereotactic body radiation therapy or perhaps radiofrequency ablations, and continuing on with the agents as patients still tend to derive clinical benefit. However, people who are purists will often look at clinical trials and say that the only relevant outcomes are those that are objectively measured, such as progression-free survival and overall survival. I tend to fall into the first camp, which suggests that it's a very clinically meaningful endpoint, and it is something that we typically do in our practice on a day-to-day basis. I think clinicians will choose an agent based on a multitude of factors, one of which may be overall survival. Others would be progression-free survival, quality of life, or response rates. It really depends on the action that the clinician is trying to achieve at that particular moment in time. This is not a new phenomenon. In many other spheres in cancer treatment, we have options where there are not clear-cut differences between these endpoints. A notable example of that would be hormone therapy in breast cancer therapy, where there are many different agents and they're all fairly similar. In my view, it will really be a clinical-based decision between you and the particular patient in front of you. There are many advantages to using one versus another for different reasons, perhaps dose selection, perhaps a toxicity profile, and or a progression-free survival you're trying to achieve. Again, the ultimate decision will be on an individualized basis. Afatinib is a drug which has the ability to dose reduce, whereas some of the other drugs are typically just a once daily dose with no ability to change that dose. What we know is that these drugs have different pharmacokinetics in different people, and that for some people a full dose of a drug may impart some additional toxicity, much like chemotherapy does in the vast majority of people we treat with chemotherapy. We know that imparting a dose reduction can often modify and ameliorate many of the symptoms that they may experience and allow for continuation on with the agent with good effects. Again, similar to chemotherapy, this may require a bit of adjustment, but is definitely very reasonable to do, and we are capable of doing that without much difficulty. Dose reduction can often lead to a reduction in AEs and allow for more manageable use by the patient. It is something that we would do in conjunction with good supportive management, of course. It's not something that we would do in and of itself, but it is very simple to do. And we know that using a strategy such as that does not impart on its clinical efficacy, which gives us more confidence in the route that we're taking. So when I reduce a patient on afatinib, I find that if they're needing of that, many patients don't need to have a dose reduction, but if a patient does require a dose reduction due to a side effect issue, my experience thus far is that when you do that and you combine it with of course, the necessary supportive treatments that you might need to do, that a patient will tolerate this very well and be able to continue on with the drug without any further interruptions. Another important element, of course, to consider is whether or not the dose reduction in and of itself will affect the efficacy. The evidence suggests that even with dose reductions, when appropriately used and when a patient is able to continue on with the agent, that efficacy and overall outcomes are not impaired. The information regarding quality of life is also quite encouraging. We do recognize that while we are able to reduce the AEs by reducing the dose of afatinib, that this again does not translate into a reduced efficacy, and nor does it translate into reduced quality of life. In other words, symptom control measures seem to be maintained or improved relative to other potential treatment strategies.